I have the pleasure of introducing our next presenter, Karen Kluin. Karen received her master's in speech-language pathology from the University of Michigan. She's a supervisor in speech-language pathology and clinical assistant professor in the Department of Neurology at the University of Michigan. She is an American Speech-Language Hearing Association certified speech-language pathologist at Michigan Medicine for 44 years and is board certified from the Academy of Neurologic Communication Disorders and Sciences for 30 years. Her expertise includes neurologic motor speech, language, cognitive communication, and swallowing disorders due to Parkinson's disease, atypical Parkinsonism, Wilson's disease, dystonia, ataxia, brain tumor, epilepsy, ALS, neurodegenerative diseases such as primary progressive aphasia, primary progressive apraxia of speech, and stroke. She also performs intraoperative and extraoperative brain mapping studies and monitoring of motor speech, language, motor functions during awake craniotomies for tumor and epilepsy, as well as intraoperative testing during DBS surgery. So very impressive, as you can tell. So with that, we'll have Karen do her presentation and then end with a Q&A.
Thank you so much. Thank you very much. It's a pleasure to be here this afternoon. We're now going to switch gears and get away from walking, and we're going to move up the body, and we're going to focus on talking and finding words, and then on swallowing, okay? So with that, as you know, Parkinson's disease can cause reduced range of motion, paucity of movement or hypokinesia, slowness of movement or bradykinesia, rigidity, and tremor. And when they all these features can adversely affect motor speech production. And when that happens, it's called dysarthria. And the specific type of dysarthria is called a hypokinetic dysarthria. So what I thought I'd do is go through the common deviant motor speech dimensions that one sees in hypokinetic dysarthria. And motor speech includes respiration, having air come up through the vocal cords, having the vocal cords vibrate, producing a tone, which then is resonated into our oral and nasal cavity. So there's 5 basic motor speech processes. They are respiration, phonation or voicing, nasality or resonance, articulation, and then the rate of one's speech and the melody or the prosody. So in Parkinson's disease, in terms of respiration, there's often decreased breath support, so you're not able to get enough air up. In terms of phonation, you have a low volume level, or it's called hypophonia. But the one unique feature of the hypophonia as seen in Parkinson's disease is this amazing ability to increase your volume when someone tells you to do it. There can be loudness decay, a mono pitch or evening of the pitch level, and occasionally there might be inappropriate silences or difficulty initiating voicing. In terms of articulation, there's imprecise phonemes, especially during the rapid rate of speaking, and occasionally you might hear disfluencies or repetition of sounds, words, or even whole phrases. And if it's repetition of sounds or short words, that's called disfluency. When there's compulsive repetition of words or phrases in the context of an increased rate and decreased volume, that's called palalia. In terms of the prosodic features, one hears short rushes of speech, increased rate over time, and decreased stress patterns. Dysarthria treatment is aimed at improving the volume and voice quality, as well as improving the clarity or intelligibility. And we do that via use of dysarthria treatment strategies, either with a traditional program or, when appropriate, the loud or speak out programs. So at this point, I think there's more than just the loud program. One can improve voicing volume, which includes volume and clarity, as well as intelligibility, by other means. The Loud program is not the only program that's available. It does work, it's successful, but you have to keep at it. It is not something that is done to you at one short period of time. It needs continually practice every single day. The Speak Out is a program with similar focus. It's speaking with intention. So what I'd like to do now is review the dysarthria strategies, and maybe you could follow. At the end, I thought we would all practice using these with a short treatment program. So the first thing is important to sit upright. You want to take a breath of air in, and it's better to take a breath of air in through your nose. Those little hairs that we have in our nose, they help filter out any little particles that are in the air. If you continually breathe in through your mouth, sometimes little particles in the air can set off your vocal cords, and they become irritated, and you end up coughing a lot. So taking a breath of air in through your nose, and thinking about speaking more loudly, keeping a slow rate, pausing frequently, so it's limiting the number of words spoken per breath, and then saying all the sounds in the word, but especially saying the final sound. So move your lips, over-articulate, make sure you say all the sounds in the word. Sometimes, though, we're not able to meet our communication needs by using normal speech. And so what I wanted to do was just to review that there's augmentative and alternative communication devices that are available to allow people to then communicate their needs, since it's so vitally important to be able to communicate our wants and needs and ideas. Augmentative communication means adding to the individual's motor speech production. Augmentative is something used instead of the individual's motor speech. And here's just some examples of low-tech AAC options, such as writing, such as using a letterboard, or pointing to photos or pictures or written words on a personalized board. More high-tech AAC options include using cell phones, tablets, computers, and downloading text-to-speech apps, which are many, and they're free. All you need to do is go to the Apple Store, look up augmentative alternative communication or AAC apps, and a variety of them will come up. Many of them are free for a trial before you purchase them. I wanted just to review that language skills include your ability to understand spoken language, follow directions, answer questions. Includes our verbal expression, our ability to find words, put words into sentences, and grammar skills. Reading comprehension, or reading a printed material and comprehending it, and writing. Writing is a symbol system, so if you have trouble finding words, saying them, you're going to have trouble finding them by writing. In Parkinson's disease, language changes can occur. They most often are commensurate with the person's global cognitive status, but many times people have told me that they have trouble finding words, and that's called dysnomia. And there are different strategies one can use to facilitate or compensate for the word-finding difficulty. And also, if your cognition is starting to change, you might have difficulty following lengthy directions or commands, or understanding when people give you too much information. And so one good strategy would be to make sure you ask people to speak more slowly, to emphasize the key words, and to use maybe more simple grammatical structures. This is following up what Dr. Albin spoke about earlier, that there are cognitive changes, and they're most notable in executive skills, right? So that includes attentional control, working memory, cognitive flexibility or shifting from one set to another, as well as reasoning, problem solving, and most importantly, internal self-monitoring. And I think that's one of the first things that I see can become affected in Parkinson's disease is inability to monitor or self-cue. And so people do much better when they've been given external cues, such as speak more loudly. As you know, that executive skills are really important for us to help monitor our behaviors and to help facilitate achieving our goals. So, impaired internal self-monitoring skills, there's a need to compensate for that. People need external cues, and this is most noticeable with use of dysarthria strategies. So even if the world was perfect, I would expect people to use dysarthria strategies 100% of the time. It's not reasonable. However, I do expect people to use them 100% of the time. If somebody leans into you, gives you a quizzical look, or says what, then people should immediately speak more loudly, speak more slowly, over-articulate. Let's switch to swallowing. Once again, the characteristic features of Parkinson's disease, the reduced range of motion, the slowness of movement, the diminished movements, rigidity or tremor, can adversely affect your ability to swallow. And the medical term for that is called dysphagia. The causes of the impaired swallowing in Parkinson's disease is due to cranial nerve involvement, specifically 5, which is trigeminal, the jaw, 7, which is the face, 9 and 10, which is the soft palate. So put your tongue in your mouth straight up. That's the hard palate. Move your tongue back. That's the soft palate. 9 and 10 control the soft palate so that the muscle closes your mouth from your nose. Also, cranial nerve 11 is involved, and 12 is the tongue. So all those cranial nerves we use for speaking as well as swallowing, but we use them in a different way for each of those functions. Here's some clinical symptoms and signs of an abnormal swallow. There can be weight loss, drooling, inability to clear the food from your mouth, the oral cavity. You could have a gurgly, wet voice quality. There could be coughing or choking before, during, or after the swallow. You could choke on your own saliva, difficulty swallowing medication, a sticking sensation in the throat after the swallow. I have highlighted here that pain with swallowing, heartburn, GERD or reflux, those require medical assessment first. So swallowing has been divided into 3 major phases: the oral phase, pharyngeal phase, and esophageal phase. And so I thought I'd just review some of the prominent findings that you would see in each of the phases. In oral phase, there might be disorganized anterior to posterior tongue movements resulting in pumping of the tongue to help move the material back. You could lose bolus control from the lips due to the disorganized anterior to posterior movement, or if you took too big of a bite. And then there could be difficulty with chewing. Pharyngeal phase difficulties can be that sense of food sticking in your throat after the swallow, one due to not chewing solids very well, or 2, that the muscles of your pharynx have become weaker and they're not pushing all the food down with each swallow. There could be episodes of coughing if the person is eating or drinking too quickly. And then there's that, as I said earlier, the sense of residual in the throat due to the decreased strength of the pharyngeal muscles. And then when material goes the wrong way and through the vocal cords and the person does not sense it, that's called silent aspiration. All of us aspirate when we eat. Everybody does, whether you have Parkinson's disease or you don't. But what we do is we are able to clear it by getting up and walking around. When you have Parkinson's disease, we just don't want those episodes of aspiration to increase because it's the adverse effects of the aspiration that are most worrisome. Because too much aspiration and not clearing it can result in an infection. So the swallowing goal includes facilitating swallowing through use of compensations and strategies. When appropriate, one could use an expiratory muscle strength training, or EMST, as well as swallowing exercises. And if needed, there's modification of the diet. And I just thought to show you two different devices that focus on expository muscle strength training. Now, once you start doing this, you need to keep doing it. The literature shows that it's been helpful in Parkinson's disease to help swallowing, but only if the individual does it on a routine basis. And what it is that you put the device in your mouth, your lips contract around the device, and you use expiratory muscles to overload this one threshold that's set. So one is the EMST, which is a little harder, and then I also put a picture of the breather, which is a little easier. Dysphagia in Parkinson's disease is due to the progressive oral and pharyngeal dysfunction. It results in diminished reflexive swallowing. As you know, we all swallow reflexively. But when that feedback to swallow reflexively becomes altered, it results in drooling or in pooled oral secretions. So it's not that the person is creating more saliva. What they're doing is not swallowing reflexively as frequently. There can be weight loss, and then the adverse effects of aspiration. So I thought I'd review some basic swallowing suggestions, and maybe people who have some liquids in front of them can implement as I talk. So once again, you want to sit upright. And again, it's better to bring the food, the liquid up to your mouth. Going down to the table and putting your head in this position makes it harder to swallow and it's easier for things to be misdirected or go the wrong way. You want to start a meal by taking a small sip of water to moisten your mouth. Over the years of working with people with Parkinson's disease, I've heard many times that part of your mouth is dry and part's wet. And so you want to start a meal with an even moisture in your mouth. You want to take smaller sips and smaller bites. You want to swallow everything in your mouth prior to the next bite or sip. You want to try to avoid tipping your head back. You know, all those Pepsi commercials and Coke commercials where everyone's guzzling. No guzzling. No one should guzzle. But especially if there's weakness of your oral and pharyngeal muscles. You're opening up your airway for things to go the wrong way. You want to alternate liquid and solid swallows because you want to help the liquid flush things down. In case there's some beginning of weakness in the pharyngeal phase, drinking liquids will help flush any residual that's in your throat. And the key to eat and drink more slowly. Many times just swallowing again will help clear any residual. And once again, to follow up with what Dr. Albin said earlier, you know, it's sometimes hard to walk and avoid distractions or to deal with distractions, it's hard to swallow and talk at the same time. Nobody should do that. I always suggest that you try and time your medication to get maximum benefit during the meals. And it's controversial. Does the cinnamon, does the medication help your motor speech, help your swallowing? It's individual, but it's always worth to make sure that you're at your best or you're on when you're eating your meal. Again, it's important to minimize distractions, auditory and visual distractions during meals. So I suggest turning off the TV, turning off the radio, so that you can just focus on really safe swallowing. Sitting upright for at least 30 minutes after a meal helps to prevent any heartburn or reflux. And the key is maintain good oral hygiene. The literature shows that our mouth is full of germs, and so we want to minimize those pathogens from going the wrong way. I don't know if anybody here has trouble swallowing medication, but it's a frequent complaint that I hear from people that I see. And so I thought I'd just review some basic strategies. The key is to swallow only one pill at a time with small sips of liquids. I suggest you place the pill in the middle of your tongue and then swallow. If that doesn't help, then break the pill into smaller pieces. Put that in the center of your tongue with a small sip of water. If you can, and if the medication allows you to, you could crush medication. You can mix pills or pieces of pills with small amounts of puree, such as applesauce or yogurt. I tend to like applesauce because it's a puree. It will keep things together, but it's not as sticky. It's a little liquidy, and so it makes it easier to swallow. You could also stick a pill in a little piece of Jell-O and have that just slide right down. The management of the swallowing problems in PD include, as I said, good oral hygiene, implementation of suggestions for safe swallowing and strategies to facilitate your swallowing. If needed, diet modification. So sometimes just diminishing the hardness of food. So going to smaller bites, softer solids helps people. Sometimes it's better to just eat a puree diet, but then you often don't get the nutrition that you need. And this is one area that I really want to focus on, our goals of care discussion early on with your neurologist, early on with your primary care physician. It's better to have these discussions in a time when it's not a crisis, to have everything in place so that your wishes are known. And what my feeling is, whatever people decide, whether they want a feeding tube or not want a feeding tube, that's the right decision because it's your decision. And it's better to have that discussion so that you can get all the information early on, change it as you need it, but you're making decisions when you don't have to make decisions. You know, it's not a crisis. It's important to, if you need to see a speech pathologist, to make sure that they're certified, to make sure that they have experience with adults with neurologic communication and swallowing disorders. The evaluation will include assessment of your motor speech, language, cognitive skills, and swallowing. And then we formulate an individualized treatment plan based upon what your strengths are and what areas we need to address or improve. I also suggest if people are still driving, that they carry a card with them that says you have Parkinson's disease and that's caused a change in your speech, so it's not as clear, so that should you get stopped by the police, they won't think that you've been drinking. And patients that I see, I write it on the back of my business card, but it would be probably better to have it from your neurologist. And then I suggest that people just put it right behind their license, and so that it's used in an emergency situation. So in summary, I wanted to say that hopefully I emphasize the need to discuss your goals of care early and when not in a crisis situation. That the speech pathology assessments can identify changes in motor speech, language, cognition, swallowing. It's good to see a speech pathologist periodically so that strategies, modifications can be updated. You want to maximize your ability to communicate, either by speaking or, if needed, by augmentative communication systems or devices. And then it's really important to reduce the adverse consequences of a swallowing impairment. And that's it. But what I'm going to end with is having everybody sit upright right now. I want you first, I want everybody just to look straight ahead at me. I'm going to do a brief cranial nerve exam so you know what I'm talking about when I said different cranial nerves. Look straight ahead at me. I want you to smile. I want you to pucker your lips. I want you to pucker and then smile. Pucker, smile, pucker, smile, pucker, smile. Good. Puff out your cheeks with air. Perfect. Now I'd like you to open your mouth, close it, move your jaw from side to side. Good. And now stick out your tongue, move it from side to side. Good. Put your tongue to your upper lip. Put your tongue behind your upper front teeth. Put it down. Say N. L. Good. Stick out your tongue, and now move it from side to side. Ooh, very nice. Now I'm going to have you open your mouth, and normally I would look in the back to make sure that your soft palate's symmetrical. And then I would test to see if you had a gag, which I won't do today. But the next thing that I'd like you to do is everyone should sit upright. Take a deep breath of air in through your nose. Let it out slowly. Take a deep breath of air in through your nose. Now say, ah. Perfect. Whoa. Now take a deep breath of air in, and as you're letting it out, I want you to say E for as long as you can. Okay, you can stop. Very nice, very nice. Okay, we're now at the point where I want you to say the vowel sounds slow, loud, and clear. A. Very nice. Okay, so I looked at your lips at rest. I looked at your lips during movements, right? Now we're going to see how well your lips are working during speech. The sound that I want you to say is pa, 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 over and over again until I tell you to stop. Ready, go. Stop. Nice. So I count how many puzz people say in 5 seconds. And now we're going to look at your tongue tip movement, and you're going to say ta, ta, ta. Ready, go. Stop. Good. And now I'm going to look at the back of your tongue and the soft palate movement, and you're going to say ka, ka, ka. Ready, go. Stop. Good. And now you're going to put all 3 sounds together. Putaka, putaka, putaka. Ready, go. Ooh, I heard some of you get faster over time. Let's try it again, where you're going to say pataka, but slow, loud, and clear. Ready, go. Good, okay. Now what I'd like you to do is say the alphabet, slow, so each letter is clear, loud, and go. Can you say the alphabet? A, B? Is that what you were? Try it again. Perfect. So you really want to over-articulate. Let's try this one sentence. Say, near the table in the dining room. Go ahead. Good, good, okay. And then those of you that have liquids in front of you, I want you to take a small sip. Sit up, everyone's sitting upright, small sip, and swallow everything. Perfect. And now I'll open it up for questions.
Oh, I got a microphone.
Or they can get the speak out. Oh. Where the breather is available.
The breather, you can purchase it on Amazon.
Thank you.
I think that gives you the best price. Yeah. It's called the breather. The breather, yeah. And the other one is called EMST. Yeah, the breather comes with like a little, comes with the device. Let me go back and I can, comes with that device, and then it gives you instructions, and it even includes a table to help you practice every day. So the literature shows it's effective, but the literature shows that you have to keep doing it to maintain the effectiveness. And that's what all these strategies are. You have to incorporate them into your normal life and practice. And let people give you gentle reminders. Gentle reminders are okay.
I've been using the breather for about a year and a half.
That's good. Nice.
Hi. When would you move from the breather to the EMST?
When you achieve you can overload the thresholds too easily. It's resistance, so you're gonna put your lips around that opening and then you're gonna blow out. And you're trying to overcome a threshold that's been set. It would be better you can do this on your own, but it would be better to see a speech pathologist, to have an evaluation, and then to work through, see what they suggest based upon your individual needs. I'm just bringing it up because one is to help emphasize the point that you have to do these things on a regular basis. And even the loud strategies, you need to practice those on it. You have to continue to practice those on a regular basis to have the effects of it, the benefits of it.
What about the feeling of you have to clear your throat on a regular basis?
That could be due to reflux. It's not time linked to swallowing. You don't, yeah. I mean, I would discuss that feeling with your physician first and to see if you have other symptoms or signs of reflux. Reflux is so common.
You just gave us an incredible amount of material. In
Too much?
No, not too much, but I'd sure love a handout.
Well, I think what would be better is for you to have an evaluation by a speech pathologist so that all these suggestions, these are all, it's a whole list of suggestions so that the strategies and suggestions would be individualized for your needs. That's the key. But there's 3 principles. One is I want people to speak more slowly and eat and drink more slowly. I want people to limit the number of words they say per breath, and I want you to take smaller bites and smaller sips. So those apply to both, but it's really important to have individualized suggestions to meet your needs, and that's the key. A speech pathology evaluation is you're seen individually, and a complete evaluation's done, and then we formulate a treatment plan that's best suited to meet your needs.
Finding, how much of that is related to memory more than articulation?
You're right. So at one point, word finding and thinking and memory come together. But and in Parkinson's disease, that's mostly what the word finding difficulty is due to. But in other cases of other types of patients that I see, you can have just focal word finding difficulty. It's called dysnomia. So say, let's see, I'm going to see this object right here. Oh, I'm calling it a table. A table for a chair. That's a semantic or a verbal phrase. I would say to the person, you said table. It's not a table, it's a, and then the other say chair. That's a strategy to help. Look, let me go back up here. I can give just basic word finding strategies. If you can't find a word, you want to chill out for a second, because if you get anxious, it makes it harder to find the word. Then you want to think of a word that has a similar meaning, right? Or you want to beat around the bush. Tell what you do with it, the shape, the color. Because many times by doing that, that helps the word to pop into your mind. And if people around you know what you're trying to say, if they could give you the first couple sounds, that would help. Because
Her
see
question.
her question was, is it important to have you mean like a video fluoroscopic swallow study as a baseline? Yeah, I personally don't, because I don't want to, so personally, I like to see people clinically and I do a cranial nerve exam, and then I watch them eat and drink different consistencies. If my clinical exam doesn't answer my question, then I'll recommend a radiology exam. But you're exposed to radiation, and I don't want to expose people to radiation unless it's really needed. With a speech pathologist or with me? So you ask your neurologist, and they send a referral. So at the hospital, I see all the patients who are being evaluated for deep brain stimulation. So I see people prior to surgery, and then I go into the operating room, and I'm watching people's face and listening to their speech and giving that feedback back to the neurologist and neurosurgeon. And then I see people post-op day 1, and then I see them once their DBS is tweaked to the very best level to see how they're doing. And I like to follow people, so I have them come back at least once a year, if maybe more frequently, to keep tabs on people. If I think that they could benefit from a treatment program, then I refer them to our outpatient sites, which are at Med Rehab, at Canton, and at Brighton. I'm in a I feel so lucky to work at Michigan Medicine. I work with great social workers like Erin and Laura. I mean, you can't get better than that. And then I work with great neurologists like Dr. Albin. All the movement doctors at the hospital are amazing. And they're really interested in maintaining the quality of people's life. And that's why talking to them about your goals of care is really, really important. Do I see in their speech? Yes. If the stimulator is up too high, it can cause a tightening of the voice, which is different than the speech problem in Parkinson's. So the nerve involvement of different parts of the nervous system affects motor speech in a different way. So people with PD have a hypokinetic dysarthria. People with an atypical Parkinsonian syndrome, such as PSP, they're going to have spasticity in their speech as well as the hypokinetic. By listening by examining and then listening to the speech, I can help give the neurologist additional information for their evaluation. You know, neurologists are really good at putting puzzle pieces together, right? And so the motor speech language is one of the pieces that they can use. Yep. Yep.
Any
Okay.
other questions for Karen? Okay. Well, again, thank you so much, Karen.
You have one
Oh,
more. You have yeah. I think breathing can be affected. You don't get enough air. So that's why working on taking a breath of air in, sustaining every day is helpful too. But I think what I would do is breathe through your nose and limit the number of words you say per breath. Pause more frequently for air in. Because that's where our volume is. If you don't get enough air in, you're not going to have a good voice. So with that, then you have to compensate. So that's why I always examine that, because if people can't sustain for a long time, then they're going to have to take more frequent breaths when they're talking to compensate for that.
I was going to say, someone with acid reflux, is it always best for them to, when they're chewing their food, chew it well, not a big amount of food, and then drink a liquid directly afterward?
Yeah, I think if you have, you want to make sure that, I think, flushing solids down is effective, yeah. I mean, if your voice is really hoarse, and hoarse I just define as a combination of harsh and breathy, then you need to talk to your family doctor, because there is, there's the GERD type of reflux, but there's also laryngeal pharyngeal reflux, which means that the reflux is going up to your vocal cords and irritating them. Yeah. Did I answer your question? Okay. Well, thank you for your attention.
Sorry, you mentioned taking the medication like Seminex in time to coordinate it with your eating schedule?
Yeah, so that you get your feeling on, so that you take your medicine and you feel, it's effective. And so that you have, your muscles are going to work more effectively. Does that make sense?
Well, I have to take my Seminex 3 times a day, so it's very difficult. I can take it just before breakfast, perhaps, but at night, we're supposed to have at least 6 hours gap between taking it. So it's,
Yeah, well, if you take it 3 times a day, if you get up in the morning and take it, and then you have breakfast a half an hour, 20 minutes after, you take your medicine, and you do that for noon and nighttime,
but you're supposed to have 6 hours between.
yeah.
That's, so, okay.
The literature's mixed on whether the cinnamon helps or not, your motor speech or your swallowing, or your swallowing. But I always say, if it's possible, to make sure you have that you eat your meals when you're on,
Yeah,
right?
I understand.
Yeah.
Thank you.
Yeah, so, I mean, that's the other thing. I always ask people in my examination when they took their last dose of Cinnamate, so that I can have an idea of my results in terms of the cycle of medicine. Key is, though, that if you're noticing changes with your speech, language, swallowing, that you get a referral and that you see a speech pathologist so that they can evaluate you carefully and then formulate an individual program for your needs.
Thank you so much, Karen. And thank you, obviously, to our other presenter, Dr. Carly and Dr. Elvin, for all of your time and expertise today. Amazing presentations. And with Karen, you didn't even know you were going to get a presentation and a free assessment today.
A free treatment session.
Yeah, exactly. And thank you, obviously, to our vendors for sharing resources, information. To all the vendors who are still here, feel free to pick up information and resources at the tables. And obviously, thank you to you all for your time and attendance and attention today. Again, we love having these programs. Thank you all for showing up. We want to keep having these programs, so always let us know what's most important to you, what topics are most relevant, and what's most impactful. So thank you all. And a shout out again at the back of your program. Laura Summers mentioned it at the top of the program, the QR codes. Again, the top one is to join our Michigan Medicine Parkinson's Disorders Clinic, our listserv to kind of be notified of these events in our newsletter. And then the bottom is also to access the Parkinson's Foundation store. And so again, even to piggyback on speech and swallowing resources, they have an amazing speech and swallowing book, and again, a lot of other amazing resources as well. And with that, we will adjourn today. Again, safe travels home or to wherever you're going to next. We hope you have a restful weekend. Thank you.